Um, Good evening, everybody. We are very happy to have our evening seminar. I'll switch into Hebrew and then I'll come back to English. אנחנו מאוד מאוד שמחים לארח מפגש נוסף מתמקצע ספציפית בתחום מאוד מאוד משמעותי, בתחום של דיכאון ובתחום של טכנולוגיות חדשות שיאפשרו טיפול טוב יותר במטופלים שלנו. המפגש הפעם הוא טיפול שהתמקצע ספציפית בתחום של גריעה וגלית, we are very happy to have our distinguished colleague from Baltimore, Professor Scott Aehrenson, which is the director of the clinical research psychiatry at the Shepherd Part Clinic, and he is also a clinical associate professor of psychiatry at the University of Maryland School of Medicine. We were very happy to have you, Professor Aehrenson, because of your important influence on the field of VNS. VNS, vagal nerve stimulation, is approved by the FDA and the CE of the European Foundation for the treatment of depression since 2008. And around the world, about 200,000 surgeries have been already performed, most of them for epilepsy, and about 5,000 cases for resistant depression, most of them in the US and Western Europe. We will be very happy to hear from you about your important research about the subject, because you are one of the leading researchers in this field. So it's so important for us to hear. In Israel, this procedure is approved. Most of the experiences is in epilepsy, and we are very happy to inform you that Ido will maybe tell us later, Dr. Strauss, that this month our first patient will be treated by this procedure, and we will have our first experience of Lev Sharon Mental Health Center with Ichilov or Soratsky, or how they call themselves today, in this field. So we will have our experience in the field too. This year, we will also the company will try and introduce this technique into what we call the Sal HaBriut, which means that if resistant depression patients will have the right indications, they will get this treatment by their insurance companies. So because you have such a lot of experience and you've written so many interesting studies, and your study about VNS is one of the leading ones, except for your experience in TMS and other measures, we are very happy to have you as our speaker. After Professor Aehrenson will finish his lecture, we will have a continuous lecture by Dr. Ido Strauss, which is, I will introduce him later, but he is leading the neurosurgery unit in Ichilov, Soratsky Ichilov, and he has implanted these devices for epilepsy many times already, and he is collaborating with Dr. Pfeffer in our mental health center to start implanting them for depressed patients. At the end of the sessions, which won't be very long because we know that it's a late hour, we will be very happy for having a stimulating conversation. People will be able to ask questions. The more you can intervene, it will be better. So with no other ado, so we will be very proud to have you, Professor Aronson.
Thank you so much. I'm going to share my slides. And can everybody see my slides?
Yes. Very
terrific.
Good.
Okay, thank you for the lovely introduction. The only correction is, since you got my bio, I'm now actually a professor of psychiatry, and that's changed everything in my life. We're going to be talking about vagus nerve stimulation and trying to tell you where I have been with this and where I think things are going. I'm somebody who has specialized in treatment-resistant mood disorders for my whole career, and I sort of came into doing neurostimulation kind of through the back door in all those wonderful years that we didn't have other things other than monoamine-based antidepressants. These are some of my disclosures. Please know in particular that I am a consultant to LivaNova, who is the manufacturer of the vagus nerve stimulator device. So let me first just spend a little bit of time on what the paradigm for depression treatment is. And I am told that the folks on this call have a lot of experience with treatment-resistant depression, so I won't go into this too long. But clearly there are levels of treatment resistance, and generally speaking, most psychiatrists would say that there are at least two separate levels. Level one is after one has failed about 2 antidepressant treatments that may or may not include use of psychotherapy. But there's a whole other level of treatment resistance that generally speaking are when folks have failed 3, 4, perhaps even 10 antidepressants. And there's very little to guide us, particularly when we get beyond 4 failures. And I'm going to make a case for the consideration of VNS as a chronic treatment for treatment-resistant depression. I've also had an article that came out about 2 years ago that I wrote with John Rush about changing the whole nomenclature for depression to difficult to treat depression rather than treatment-resistant depression. And the main point of that is these are illnesses that are possible to treat, and treatment resistance suggests that we've got nothing for you. And that's not the way that I think we should be treating folks with this condition. And you can see on the far end of the continuum are basically all these neurostimulation techniques, although I'd argue that RTMS is something that I commonly use in this level 3 area. ECT I do tend to use in this level 4 area along with VNS, but also bear in mind that VNS is a chronic treatment, whereas ECT and TMS are really acute treatment interventions. A couple of definitions, and some of these definitions become real important, so I want to make sure that we're all talking about the same thing. We know that non-response tends to be less than a 25% reduction on a depression rating scale. The 3 scales most commonly used are the Montgomery-Åsberg Depression Rating Scale, the Hamilton Depression Rating Scale, and the Inventory of Depressive Symptoms. I'd argue that there's another level that I want folks to consider, which is a partial response. When you have somebody who has been just terribly depressed for years and sometimes even decades, if we could make these people 25% better for 5 years, I think every single one of my patients would argue that 25% better for 5 years is better than 50% better for 6 months. And one of the problems with this whole area is we're really only following people for months and rarely years. I'll show you some of the experience I've had in following people for 5 years. Treatment response is the typical cutoff is a 50% drop in a depression rating scale score over the course from when you start treatment until when your primary outcome measure is. And remission is getting to the point that you've lowered the score on these scales low enough that there's either no dysfunction or only minimal symptoms remain. And one of the problems is for people with severe, difficult to treat depression or treatment-resistant depression, it can be very, very hard to get these people into remission. So we want to make sure that we have reasonable goals. As well, response is not remission. When we can get to remission, that's better. Most clinical trials give statistics for response and not remission. But responders are 3 times as likely to experience a relapse within 12 months than remitters do. So what's our current treatment paradigm? So I've been a psychiatrist. I finished medical school in 1981, so I've been doing this a while. After 6 decades of antidepressant drug development, we basically have drugs which affect serotonin, norepinephrine, and to a lesser extent, dopamine. Most recently, and in the US just in the past year, we actually have 2 novel non-monoamine-based drugs, which is esketamine, which works by NMDA antagonism. It's given in something that's squirted intranasally. And there's a GABA modulator that has been approved now only for postpartum depression that is a several-day infusion. So it's basically a 50 to 60-hour infusion. And both of these are fairly expensive treatments. But the other thing to bear in mind with both of these treatments is these are acute treatments. These are acute treatment interventions in which we're looking, and these are actually both things that may make some people better within hours to days as opposed to the classic treatment paradigm. There are many other neurotransmitters that are likely to be involved with mood disorders. We don't have any medications to target them yet. And we actually don't even have a lot of other clear targets for antidepressants. And this is one of the huge problems we've all experienced within psychiatry, is we still don't really know what the underlying pathophysiology is of these illnesses. At least a third of patients with depression do not have a sufficient response to the existing antidepressant medications. And this is despite the addition of, there's obviously a whole bunch of things, primarily atypical antipsychotics, that have been added to the armamentarium, but also bring with them lots of challenges from the standpoint of metabolic issues. So I'm going to talk about neurostimulation. And first, what is neurostimulation? So basically, it's some kind of modulation of the nervous system, either central or peripheral, by electrical or magnetic impulses. And this is an intervention that's very commonly used in neurosurgery and neurology for a variety of different uses, including pain management, hearing and visual prosthesis, and control of Parkinsonism. So I'll mention a little bit about something like deep brain stimulation, which is not approved for depression, but is used for intractable Parkinsonism. There's a long history of psychiatric use of neurostimulation in the form of electroconvulsive therapy, which has been done since the late 30s, although our technique has gotten better. More recently, there's been a couple of things approved by the FDA for the treatment of depression, and that's vagus nerve stimulation, which has been approved actually since 2005, and transcranial magnetic stimulation was approved in 2008. There is ongoing research to look at magnetic seizure therapy, which is basically inducing a seizure magnetically rather than electrically. Deep brain stimulation, as I've mentioned, the only thing that is cleared by the FDA is just a compassionate use of deep brain stimulation for intractable OCD, as well as direct current stimulation, which currently does not have any US FDA approvals. So why do we need neurostimulation? As I mentioned, I got into neurostimulation because we'd kind of run out in the early 2000s of new targets for depression, and was asked to take over the patients that were implanted at the University of Maryland in what was going to be called the DO2 study. And that got me started within the research of neurostimulation techniques, and also became a site for the original studies of TMS for depression. There's a tendency to look at somatic therapies for depression as being exclusively neurochemical, but bear in mind that the brain is as much electrical as it is chemical. And so there are many neurotransmitters involved with mood disorders, but we have not had medications to target them. And we can alter neurochemicals by neurostimulation, as well as by neurostimulation will also alter aberrant neuronal activity. One of the most common things that you'll see is you'll actually see a greater synchronization in the EEGs of patients with depression. And curiously enough, VNS can actually desynchronize EEGs, which is consistent with the brainwave pattern of a less depressed brain. So neurostimulation offers a non-systemic somatic approach to depression, often with an improved side effect profile. And just so that folks know, as was mentioned in the introduction, there have been about 5,000 international implants for VNS for depression, and I'm responsible for about 60 implants. So over 1% of the worldwide patients treated with VNS for depression have come through my program. This is just a little chart I made up to give you some perspective on where we are with neuromodulation and depression. And obviously we're looking at ECT, TMS, and VNS. I included TDCS, which is transcranial direct current stimulation, and deep brain stimulation, despite the fact that neither of these are approved for use in depression. You can see that there is, when you look at efficacy in severe illness, we don't have a huge database within TMS. We certainly do have a big database within ECT and VNS that these can be effective interventions. Durability of response. One of the biggest problems with ECT is even if you respond to ECT, your likelihood of having a relapse within the first 5 months, depending on the study, it may be as high as 66%, it may be as low as 38%, but that's the best odds you're going to wind up getting. So figure on average about 50% of the people that respond to ECT are ill again within 6 months. TMS, we have some moderate protection from relapse. One of the problems with TMS is there is actually no approved protocol for maintenance. And lots of things we could discuss with that. One of the nicest things about VNS is we're implanting a device that is in and on for 24 hours a day, 7 days a week, continues to create a current for as long as the battery is effective, which is figure about anywhere, depending on settings. My usual is 7 to 9 years. And so we do see a nice durability of response. TDCS, we've got no evidence of that. DBS, if it works, likely has some durability of response, again, because it's an implanted device. Efficacy with episodes of greater than 5 years, as most of you probably know, most drugs that are on the market, people, in order to get on the market, you've demonstrated efficacy. The problem is generally people who've been depressed in the current episode for longer than 2 or at most 3 years are excluded from most studies. So with ECT, we certainly have anecdotal evidence. I'll show you some evidence from my VNS data set. With TMS, we really don't have a significant data set for people who've been depressed for longer than 5 years in the current episode. One of the areas that I'm most interested in is bipolar depression. And lots of different reasons for that. I actually think neurostimulation may be one of the best interventions for bipolar depression. And let's bear in mind that what is currently approved for use in bipolar depression are basically atypical antipsychotics, one of them combined with an antidepressant, but it's 4 atypical antipsychotics, 2 of them still on patent, and are really quite expensive in the US. But we do have some nice evidence for ECT in bipolar depression, some early anecdotal evidence, a lot of it mine, in TMS, and I will be publishing shortly a prospective study of TMS in bipolar depression. And I'll show you the evidence that we published from a large study that I was the first author for. There's some minimal evidence within TDCS, but a large international study did not separate within that population. So let's hone in on vagus nerve stimulation. And so the vagus nerve stimulator is implanted in the upper chest, and tunneled under the skin is the leads, which are then wrapped around the vagus nerve in the neck. And it's wrapped around, these pigtail leads are wrapped around the vagus nerve right around where the recurrent laryngeal comes off. And that's why a lot of the side effect profile is just based on where the leads are put. The surgery you'll be hearing more about. It's about an hour and 15 minutes usually done in my neck of the woods. It's done by a couple of neurosurgeons that I've worked with. A lot of neurosurgeons have experience given how often this device is used for difficult to treat epilepsy. And the device sends out a small electrical current every 30 seconds, every 5 minutes. And this is delivered 24/7 unless interrupted by a magnet placed over the device. Generally speaking, most of my patients just leave the device in and on. There are a couple of my folks, somebody who was singing in a choir would tape the magnet over the device when she'd have to sing in the choir. Another one of my patients didn't want folks to hear, and it sort of sounds like somebody's voice is breaking up a little bit when the device goes off, only for the 30 seconds the device is going off. So she was a telemarketer, and she would put the magnet over the device when she'd be on the phone. Other people, I had a art teacher who just left, didn't bother using the magnet, and she did not feel it was an issue for her or for her students. So a little bit about the mechanism of action and why we think this works. What we feel is that we're actually getting a response both from neurotransmitter expression, and what happens is the pulse goes off from the device, and it largely goes upstream, back up to the brain. And it goes through the nucleus tractus solitarius and hits all those areas of the brain that we've been so interested in depression, the locus coeruleus, the frontotegmental giant cell field, dorsal raphe nucleus. And what we can find is that we can actually increase extracellular amounts of norepinephrine, GABA, serotonin, and decrease extracellular amounts of aspartate. We can also see an increase in cerebral blood flow in the thalamus and in the cortex, as well as I mentioned before, a desynchronization of EEG rhythms. So you actually get this antidepressant effect across neurotransmitter expression, cerebral blood flow, as well as changes in the EEG, and the EEG becoming more desynchronized. This is actually data from, this was the first study I was involved in. This is a paper on that first study called the DO2 study. And the main reason I put this up here is this is looking at response rates over time. And this is looking actually at the 3 different scales that I had mentioned earlier. And what is so curious is, when have you ever seen a treatment for depression that gets better over time? So we get initial responses at 3 months. We get better responses at 6 months, even better responses at 9 months, better responses at 1 year, and even better responses at 24 months. This has also been a little bit of a bedeviling point in terms of demonstrating efficacy, because the original DO2 study used as its primary outcome measure how people were doing basically 8 weeks after the device was in and on, compared to other people in which they had the device but not turned on. And it turned out to be not a long enough time to see enough separation between the groups. There was also another study that I'm not showing the slide for, that was randomized to different amounts of charge. And what happened with that study is, it turns out that even low amounts of charge are effective enough that we didn't separate. The hope was that the low dose stimulation was going to be like a sham treatment, but it was effective enough that actually we didn't see a separation. Mostly what I'm going to be talking about is a quite large study that I was the first author for. And this was the VNS registry. This was a 5-year prospective, open label, non-randomized observational study at 61 centers. And we basically compared close to 500 patients who had the VNS device, compared to 300 patients who got treatment as usual. Please bear in mind that both of these groups were treated by the same doctors. And the treatment as usual group could get any intervention other than VNS that included ECT. So these were all folks who had failed at least 4 treatments. They could be unipolar or bipolar depressed. We rolled a couple of people over from the dose finding study, and the folks who came into the study for the just for the registry were able to choose whether they got VNS or treatment as usual. And subjects were followed for 5 years. So this is really the largest and longest study that I can find in the literature of people with really impressively difficult to treat depression. And let me show you what these folks looked like. So first off, average age was about 50 years old. There was a higher percentage of women than in men, as is true of most antidepressant trials. You'll see that it's about 2/3 women, 1/3 men, mostly white patients. Average age of initial onset of depression was age 20. Average age at initial diagnosis was age 30. So these folks were depressed between 20 and 30 years on average. Average number of failed treatments, you'll see, is about 8. That's actually a low estimate. And that's a low estimate because in order to get to the study, you needed to have failed at least 4 treatments. And a lot of the study coordinators, by the time they had logged at least 6 or 7 or even 8 treatments, became a little bit less aggressive in determining exactly how many failures. But please know that many of my patients had failed 12 to 16 treatments before they were put in this study. Over half of these folks in total had a history of getting ECT. And again, I think that's a very good marker for treatment severity and chronicity. You'll also notice that more of the VNS patients had a history of ECT compared to the treatment as usual. And the treatment as usual folks were actually not quite as sick as the VNS folks as you might imagine. If you're given the choice, it's going to be the sicker folks who are going to choose the more aggressive treatment. Many of these folks had been hospitalized, and I'm sure in Israel it's no different than it is in the US, that to get hospitalized for depression, these are generally people who have quite severe illness, are unable to care for themselves, or are in fact quite suicidal. Suicide attempts over a lifetime, many of these people had made some quite significant suicide attempts. So this is an unusual population for antidepressant treatment. And certainly the sickest folks that I've ever had in any studies are my folks who've been in VNS trials. As I mentioned, we could include people both who had unipolar depression as well as bipolar depression. You can see that somewhere between 15 and 20% of these folks actually had bipolar depression. Majority of folks actually had recurrent severe illness. Again, not a big surprise. So how did folks do? Here is my overall graph, and again, this is all in the American Journal of Psychiatry paper. I believe it was July 2017, if you want to see the original paper for this. Primary efficacy endpoint was whether you met response criteria. And this is a cumulative graph. So this is anybody that ever met response criteria during the course of the 5 years of study. And notice that first off, we see a nice separation even at 3 months, but notice that the separation gets better initially, and then the two lines stay rather dramatically apart. The good news is we actually do awfully well with the treatment as usual folks and even get them up to about a 40% response rate, but we get up to about a 67% response rate for folks who got the VNS. The p-value was less than 0.001. Perhaps the more important number, and I hope that you guys all understand what an NNT is. It stands for number needed to treat. And that's how many people do you need to treat with a novel treatment to find at least one person clearly benefiting. And the NNTs that I'm going to be showing you are about as low as I've ever seen, and these folks are about as sick as I've ever seen. So NNTs for many drugs on the market are, I know that there's a British Society of Psychopharmacology, and they've decided that the cutoff for a reasonable drug would be anything less than 10. There's actually several treatments on the market that have NNTs of greater than 10. And even if you compare, a typical thing that we do for difficult to treat depression is if you failed an SSRI, we go on to an SNRI. And the NNT from going from an SSRI to an SNRI is 22. You actually need to treat 22 people to see one person who benefits from that change. But here we've got an NNT of 4. This is the time to first response. So this is, again, a rough idea as to at what point do these people start to respond to the treatment. And you see that I get to the 50% point of people responding just a little bit, figure it's about 9 months that I get to that 50% point. Whereas to get to the 50% point for treatment as usual, I pretty much almost need to go out the entire 5 years. One population you've heard me talk about are these folks who've been treated with ECT, and a large number of these people who were in this study were treated with ECT. And so what we did is we broke it down into doing a sub-analysis of everybody who was treated with ECT, and we collected data about ECT exposure. So in order to qualify for this sub-analysis, I wanted you to have had at least one course of 7 ECT. And then we looked at whether you were a responder or not. And I had a fairly low bar to consider somebody a responder to ECT. The bar I used was, are you better at all? And did anybody think you were better? And if you had, let's say, 6 courses of ECT and only responded during 1, I considered you an ECT responder. If you had just 1 course of ECT but didn't respond, I considered you an ECT non-responder. And these are the results I get. So if you've ever had ECT and responded, I had a 71% likelihood of you responding to VNS. But I do pretty well with even the ECT non-responders and get close to a 60% response rate. I've got NNTs of 6 for the ECT responders and at 5 for the ECT non-responders. I'm sorry, I went ahead too far. This is another graph, and here we're looking at response by bipolar versus unipolar diagnosis. And we do very, very well with the bipolar depressives. We get about a 67% response rate, NNT of 4. I'm sorry, I just reversed it. For the unipolar, 67% response rate. Get a 70.5% response rate for the bipolars with an NNT of 3. That's the single lowest NNT you see during the whole study. And partly that's also going to be because we've got so few adequate treatments for bipolar depression. This is the remission data for that same population. And again, I see a larger separation between the VNS bipolar group and the tau bipolar group. NNT of 4 for the remission rates for the bipolar folks. This is by length of current episode. So this is just looking if the current episode is greater than 5 years or less than 5 years. And if it's greater than 5 years, we still do pretty well. That's the second bar from the top. And you see that we get to about a 62% response rate if it's greater than 5 years, but a 72% response rate if it's less than 5 years. NNTs here of 3 and 4 again. As well, anxiety is something that excludes people from a lot of studies. And even if you meet the criteria for baseline anxiety, so this means that at baseline you scored on the mini, which is our diagnostic interview, as meeting criteria for generalized anxiety disorder, we do pretty well with baseline anxiety as well. Here's another interesting graph. Chuck Conway and I, between the two of us, Chuck has done as well between 50 and 60 implants. And he and I both noticed that a bunch of our folks were better than we expected them to be in terms of functioning in life. I'll give you an example of one of my patients that did not meet response criteria. She was somebody who was one of those folks, been depressed for longer than 5 years, nothing ever worked. She basically spent a good deal of her life on the couch, would wake up every morning feeling like she needed to kill herself. About 6 to 12 months after being implanted, she comes into my office and says, you know, for the last several weeks, I no longer wake up feeling like I need to kill myself, and I'm enjoying riding my bicycle. She actually only had a drop of about 25% on her MADRS score, but she would easily tell you that she had a dramatic improvement in her quality of life. She no longer felt like killing herself. She enjoyed something. She enjoyed riding her bicycle. So Chuck did a comparison looking at quality of life measures compared to MADRS score decreases. So we use the Q-less-Q score, which is a quality of life measurement, and these scores go up rather than down, so greater quality of life is a higher score. And what we found is that to meet a minimally significant difference in quality of life, which is about a 12% increase in your quality of life score, the folks who got implanted only needed about a 34% drop in their MADRS score to meet that quality of life significance, whereas the people who are getting treatment as usual needed a 54% drop in MADRS score for the equal improvement in their quality of life. So some key points. We have a large 800 patient, non-randomized, naturalistic study of folks, and we were able to show some pretty significant separation, as well as improvement in quality of life, as well as depression scores. It was on the basis of this research that the Centers for Medicare and Medicaid in the US reversed their non-coverage determination. And so we're actively enrolling in a Medicare-funded study, which is a randomized controlled study in which we're looking to implant up to 1,000 people with unipolar and bipolar depression. And in half the people for the first year, we'll turn on the device. The other half, we will not for the first year. And hopefully we can see a very nice separation. But VNS may provide a pretty unique chronic support for patients with severe treatment-resistant depression. And a key target population may be those patients that we've got who've required multiple courses of ECT or maintenance ECT. And what I decided to do was publish a paper, and there's a paper that's currently in press of 5 unipolar, 5 bipolar patients. It's 8 of my patients and 2 patients from my buddy Hamish McAllister Williams, who's in the United Kingdom. And what we did is we looked at the results from 10 people who were getting maintenance ECT when we implanted them. 1 year after implant, 7 of those patients no longer required maintenance ECT or any acute treatment of ECT. And we had an additional patient at year 2. So after 2 years, 8 patients no longer required ECT. And we also saw a significant improvement in the clinical global impression severity score at year 1 and year 2. And that's the graph from the paper that shows the separation in the CGI score. And it's really a pretty profound separation. So on average, we're taking people down from a score of 5, which is consistent with a marked depression, and taking them down to a 2, which is basically suggestive of a minimal depression. I'm all in favor of changing the treatment paradigm for difficult to treat depression. I am a firm believer that it's better to make somebody 25% better for 5 years than 50% better for 6 months. We need to change for a lot of these people the idea that remission is the only outcome that's tolerable, but how realistic is it? And I think we need to shift focus away from the quixotic search for a cure to management of symptoms and optimizing the quality of life, not unlike we do with people with diabetes or with high blood pressure. A little bit on the criteria for picking patients. We're looking for folks who have failed at least 4 prior treatments. They can be unipolar or bipolar depressed. They need to be depressed in the current episode. Doesn't matter if it's months, years, or decades. They can have comorbid anxiety. We actually, I'm doing another analysis on that data set, which we're looking at the people who met criteria for PTSD. And patients who've responded to ECT, I think, are particularly good candidates. Folks who are not good candidates are people who are at acute risk of self-harm. Bear in mind that it takes a good 6 months to see initial response to VNS, and so you don't want to use this to address immediate risks. And excuse me, consider the course of their illness, and suicide attempts and self-injurious behavior, as well as poor frustration tolerance, are not good prognostic things. And in terms of from my experience, I think a temporary response to medications or neurostimulation is positively predictive of response to VNS. I think a realistic perspective by the patient is helpful, and there's a whole other conversation about talking to patients about VNS. As I'm a firm believer in under-promising and over-delivering, as opposed to the opposite way. And when dosing, titrate up to the best tolerated parameters. There is a positive correlation between the total delivered stimulation and the outcome. And I'm going to pass this back, and we'll hear a little bit more about the surgery.
Okay, thank you very much for the very interesting talk. I think it was very striking and convincing, a lot of evidence to show us that there's a new way of helping our patient. Maybe just before we go to Dr. Strauss, we can have one question from the audience, just because it's a late hour, so let the audience be active participants. So if anybody wants to have a quick remark. If not, maybe I have a question. Can you tell us about devices which are not implanted but are external? Do you have any experience in these kinds of devices?
Well, certainly with TMS, I have a lot of experience. There are a couple of external vagus nerve stimulators that there's a device that gets clipped onto the tragus of the ear because there is a branch of the vagus nerve that goes there. I think that the problem is they're not looking at the severely treatment-resistant folks. And so there is some positive data. This thing is only clipped to your ear for minutes to a couple of hours a day. A lot of those studies are from China. I know that my buddy Mark George has been looking at this. I haven't been real impressed by the external devices. There is a question some people have brought up that could you predict, based on a response to an external device, whether somebody would benefit from an implanted device? And I'm unclear on that, and I haven't ever seen any data on that.
Okay, thank you.
Is it possible to ask a question?
Of course, go ahead, Edith.
Yeah, just quick questions. Did you see any cases of hypomania or acute mania with the VNS?
So the one case that I've ever seen is actually, if you look at my article and you look at the patient perspective, that's somebody I implanted who has bipolar disorder and full-fledged bipolar type 1 with really heartbreaking manic episodes. She has had at least one manic episode during, I implanted her in 2006, and so I've still followed her for about 14 years. And the problem is she's one of those people who doesn't tolerate mood stabilizing agents, so I've wound up having to treat her just by altering her VNS settings. My experience is with all my other bipolar patients who can tolerate lithium or valproate or one of the atypicals, it's been much easier. And even if somebody gets a little hypomanic, you can turn down and adjust the vagus nerve stimulator. This one patient really has to come in 3 and 4 times a year for me to adjust. But again, she's somebody who is run on minimal amounts of quetiapine because she can't tolerate more than 200 milligrams, and that's really not enough to provide topside protection. So it's really just been an issue with people that I haven't been able to get to adequate mood stabilization.
Thanks.
Okay, thank you very much. Before we go to our second part, now that most of the participants are here, it's a good opportunity to that our Israeli Psychiatric Association Tel Aviv branch wants to thank Sigma company for helping us have this interesting evening. They helped us get Professor Aehrenson and also Dr. Strauss for this important session. Another thing is that you can write in the chat, you can write questions, which will also be addressed at the end of the second talk. So I'd like to introduce Dr. Ido Strauss, which is also a medical doctor, of course, and he has a PhD that he has done in the Hebrew University. And he came closer to psychiatry through his fellowship in Toronto, where he met some psychiatrists that were also on a fellowship there, like Dr. Pfeffer from Lev Sharon, and they became good friends and introducing the links between psychiatry and neurosurgery, and that's very important, and we are very grateful for you for having this collaboration. Dr. Strauss is the head of the functional neurosurgery unit in Tel Aviv Medical Center, and we'll be very happy to hear your speech. You have most of your experiences in epilepsy. Go ahead.
Hi, good evening. Thank you, Professor Hirschman, and I want to thank also the Psychiatric Association for this invitation, and also Sigma Company. And also I want to use this opportunity to thank Professor Aehrenson for his excellent and interesting talk. I'm actually very excited about giving this talk because it's I think we are also about to start a neuropsychiatric program here, and we might have our first patient at the end of this month, which might give us a minimally invasive surgical opportunity to help patients that are otherwise refractory to treatments. I want to try and share my slides.
Okay, we can see it went back.
See how I can do this bigger, maybe. Okay.
Okay, we can see it, Ido.
Okay, so I want to apologize to Professor Aehrenson, but I want to switch to Hebrew for a few minutes just to explain the surgical details. My talk is going to be very short, about 5 minutes, and the slides are going to be in English. אז כמו שבעצם פרופסור אהרונסון אמר, הקוצב עצמו מחולק לשני חלקים. יש את הבטריה של הקוצב, שהגודל שלה הוא 4 סנטימטר על 6 סנטימטר, כשהעובי עצמו הוא בערך 7 מילימטר, כל המשקל של הדבר הזה הוא 16 גרם, שמחוברת לאלקטרודה דקה, שבקצה שלה יש 3 סלילים, שאותם מלפפים סביב עצב הווגוס בצוואר. הבטריה עצמה מושתלת בכיס קטן שמיוצר בדופן בטח חזה משמאל. הסיבה שאנחנו משתילים את זה משמאל זה שבווגוס השמאלי יש יותר סיבים אפרנטיים שעולים אל המוח, ולכן תופעות הלוואי הקרדיאליות הן נמוכות יותר ויש סיכוי יותר טוב לקבל תגובה. בעצם מה שיפה בפרוצדורה, כמו שבעצם כבר הזכרתי, שלמרות שמדובר בקוצב עצבי, זה לא ניתוח מוח, הניתוח עצמו הוא בצוואר ובבית החזה, פרוצדורה קצרה שאורכת פחות משעה, בערך 45 דקות, מעורבת שני חתכים. אחד, מה שרואים פה זה את הפוזישנינג לפני ניתוח. בעצם ילד עם אפילפסיה ששוכב לפני ניתוח, הוורוד זה הרחצה הסטרילית שלנו, זה הסנטר, האוזן, רואים את הצוואר, פה הסטרנום ועצם הבריח. בעצם שני החתכים זה חתך אחד קטן בצוואר התחתון, ועוד חתך בבית השחי, באורך של 2-3 סנטימטר. בעצם בחתך בצוואר, אנחנו מבצעים אותו לא בצורה שבה זה מאויר פה, אלא בעצם חתך רוחבי בתוך אחד הכפלים, כך שבקושי רואים אותו באזור הנמוך יותר. אנחנו חושפים את הקרוטיד שיט, פותחים אותה, ומזהים את עצב הווגוס בין הקרוטיד לג'אגולר ויין. מלפפים את אותם סלילים סביב עצב הווגוס, ואז מייצרים כיס קטן בדופן בית החזה, בבית השחי, דרך חתך של 3 סנטימטר, ומעבירים את האלקטרולטת אורית אל הכיס, ומחברים אותה לבטריית הקוצב. כך זה נראה בעצם אחר כך. המטופל בדרך כלל נשאר לילה אחד להשגחה, למרות שאם כן, אנחנו מנתחים אחר הצהריים, אבל עקרונית אפשר ללכת גם באותו יום הביתה. יש שני חתכים קטנים בצוואר, התאוששות מאוד מהירה, תוך שעה אחר כך החולה כבר במחלקה, ומשוחרר לביתו למחרת. בעצם המטופל מגיע אליי בערך שבועיים לאחר הניתוח לביקורת על הפצעים, לראות שהכל יחלים כמו שצריך, ומאותו רגע חוזר לטיפול של הנוירולוג במקרים של אפילפסיה, או של הפסיכיאטר המטפל במקרים של חולים עם דיכאון, כאשר התכנות עצמו נעשה על ידי הפסיכיאטר באמצעות שלט חיצוני, שמאפשר לתכנת את הקוצב ולקבוע את הפרמטרים שאנחנו רוצים. על זה כבר פרופסור אהרונסון דיבר קודם, בדרך כלל הקוצב פועל באיזושהי צורה מחזורית, כאשר הוא נותן חצי דקה של גירויים, אחת בין 2 ל-5 דקות, וניתן לשנות את עוצמת הגירוי, כך שהמטופל לא ירגיש את תופעות הלוואי. קצת על המספרים בישראל, אז בעצם יש בישראל כבר ניסיון רב עם השתלה של קוצבים וגאליים לחולי אפילפסיה. יש לזה אישור אמר לאפילפסיה משנת 2004, ולמרות שלא הושתלו, אנחנו הושתלו רק 2 חולים באיכילוב בשנת 2008, יש אישור אמר גם לדיכאון משנת 2008. הפעולה מבוצעת באופן רוטיני בארץ מאז שנת 2006, זאת השנה שבה זה נכנס לסל הבריאות, והושתלו עד עכשיו כ-1,300 מקרים ב8 מרכזים שמבצעים את הפרוצדורה, 8 מרכזים נוירוכירורגיים שמבצעים את הפרוצדורה בארץ. איכילוב הוא עד היום המרכז העיקרי, יש לנו כ-400 מקרים חדשים מאז שנת 2006, בסביבות בין 30 ל-40 השתלות חדשות בשנה, בשנים האחרונות, כאשר על זה יש עוד את כל החלפות הבטריה. הבטריה עצמה מחזיקה מעמד בין 4 ל-8 שנים, ואז צריך להחליף אותה בניתוח קטן, פתיחה של הכיס בדופן בית החזה, ניתוק של האלקטרודה, חיבור של בטריה חדשה, ופעולה שאורכת כחצי שעה, תופרים את הכיס הזה והחולה הולך באותו יום הביתה. מבחינת סיכונים, אז גם פרופסור אהרונסון נגע בזה, לא מדובר בניתוח מוח, הסיכונים הם באמת נדירים, מולה בפעולה קטנה, אפשר לחלק את הסיכונים לשלוש קטגוריות, הסיכונים שבניתוח עצמו, שבסופו של דבר נדירים, פגיעה בעצב הווגוס או דימום, מדובר הרבה פחות מ1%, כנראה שהשכיחות של פגיעה בווגוס היא 2 או 3 מקרים ל-1,000. ואותו דבר גם לגבי דימומים. התופעות לוואי שאנחנו כן רואים אותם קשורים לגירוי החשמלי עצמו, כפי שכבר הוסגר, בערך עד כשליש מהחולים מתלוננים על משהו שקשור בקול שלהם, איזושהי צרידות, תחושת אי נוחות, אבל בדרך כלל ניתן, מסתדרים עם זה. וקבוצת הסיבוכים הנוספת קשורה להרבר עצמו, בעצם אנחנו משתילים גוף זר, ויש עד כ2% של זיהומים שעולים להתפתח במהלך השנים, בדרך כלל בתקופה הראשונה סביב הניתוח. זהו, that's it, actually, what I had to say about the surgery, and again, thank you for the opportunity to present here.
I think you're still muted.
Sorry, I was muted. So I thank Dr. Strauss for the interesting talk. It's very important for us to know the practical aspects, because if we want to send our patients, we have to understand how it works and to be able to be confident to send our patients. If it's okay with you, we will go to questions that have come up in the chat. We have one question by Dr. Domani, who requested if you can, Professor Aronson, if you can address the question of psychotic depression versus non-psychotic depression.
Being psychotic on the depressed end in bipolar disorder or at any time with unipolar depression was an exclusion for the study, that pretty much for all the VNS studies. So it's not, we don't know. From an experiential end, I have implanted maybe 2 people who had some history of psychotic depression. I leave them on antipsychotics and implanted them, and one responded and one did not. But there is no indication for psychotic depression, and we really don't have a sufficient database.
Okay, thank you very much. Any other questions, remarks, ideas, thoughts? Yes, Leon Greenhouse, Professor Greenhouse. Do you want me to unmute you? Okay.
I am unmuted. How do you control the people during, I'm Leon Greenhouse, and I also work with difficult to treat depression for many years, and TMS and ECT too. And I wonder, how do you maintain the patients during the initial stages when it is kind of difficult and they're very depressed and the VNS is not working? And you're talking about 6 to 9 months or so.
Yeah, let's take the people that were getting maintenance ECT when I implanted them. What I tend to do is I tend to just continue with what I've done before, and I'm still going to offer them whatever other acute interventions are reasonable for their condition. And what winds up happening, let's say with my maintenance ECT folks, is I gradually find that they can go longer and longer periods of time without another maintenance treatment. And for most of them, by the end of the first year, they no longer required it. So I tend to be, I'll tend to see them and tend to continue to support them. There's another funny thing, though, that happens, because most of these people, when you look at who the population was for the D23 study, most of these people had been depressed for 30 years. So the fact that they are getting a treatment with a pretty impressive response rate in difficult to treat depression, that actually gives them an optimism that they haven't had. You have to be careful because again, this is one of the problems as to how you have the conversation with people. Is what I tell people is I don't expect that you're going to be feeling much for the first 6 months. And even when I'm looking, so I've had to suspend new implants because of for a while, the hospitals and that have done the implants for me were closed to elective procedures. And all the patients on my waiting list did not have a problem because they've waited so long. There is an issue, obviously, if somebody has an acute episode, and that would be dealt with the same way I would deal with an acute episode with somebody who wasn't implanted.
2 short remarks. Can you continue ECT while having the stimulation? Does it influence the procedure or the product itself? The ECT?
Yeah, what I do tend to do is I actually turn off the device before somebody has ECT. You can just use a magnet. I made the decision to actually just turn off the device in any of my folks who require ECT, and I can turn it back on, once they're in the recovery room. But other than that, no, there's no prohibition against using ECT.
Okay, and another emphasis can you make? What happens to the manic phase of bipolar patients? Do they become more manic, or?
What's so curious is, if anything, my experience is that in general, this tends to be more of a mood stabilizer than provocative for mania. So what I have tended to find is that actually a lot of my more unstable bipolar patients were actually easier to manage. The one exception is really the person who couldn't tolerate most medications. But let's also look at her path. She went from being hospitalized 3 to 4 times a year, and since she has been implanted, what do we get up to? 14 years. She's been hospitalized 3 times in 14 years. So she's really pretty darn delighted. And in general, I have found it, like I said, to actually afford a degree of mood stabilization. And generally speaking, folks are not too revved up from the stimulation. And if indeed we're tending towards that, I might turn down the device.
Okay.
Can I ask another question?
Go ahead, Leon.
How do you handle the medical legal aspects of suicide, attempted suicide with these patients? Because you have very prolonged, very depressed individuals.
Tell me what you mean by the medical legal issues.
Well, you have them sign certain type of consents or special consents, because I presume you would have suicide attempts during the initial periods or afterwards that may cause difficulties from a suing you point of view.
Yeah, I haven't really run into that. I actually do a whole lot of other research that I worry more about from a medical legal standpoint than this. In general, so even if you look at our data, I didn't show you this data, but it certainly is in several of the articles, is we tend to reduce suicidal ideation. We also have data to suggest, so we've compared completed suicides in both the VNS group and the treatment as usual group. Both groups had 2 completed suicides. And these are actually real numbers, because we were actually going into Social Security databases to determine whether somebody had died by suicide. And the difference is that we've got twice as many patient years in the VNS group as opposed to the treatment as usual group. So we actually had effectively half the number of suicide per patient year in the VNS group compared to the treatment as usual group. The problem is, and this is actually one of the awful things that has always made me kind of frustrated with research, is we generally have excluded from studies patients with significant suicidal ideation, and I wouldn't want to suggest that I would implant folks who I felt to be acutely suicidal, particularly as my main method of treatment. But we need to embrace the folks who are dealing with severe suicidal ideation. We need to include them in the studies. And yeah, because I wind up specializing in people who have been very suicidal during the course of a close to 40-year career. I have been sued 4 times, partly because if somebody comes into my hospital that everybody's worried about, I wind up having to see them and writing a consult note. So when the hospital gets sued, I'm mentioned because my notes are in the patient's chart. And I can't I think it's a fallacy to think that we can stop people from attempting or completing suicide. But I think we need to include them more, and I think we need to be less scared of lawyers. And unfortunately, there's a large number of the people with chronic severe depression who will take their lives.
Good point. Good point. Thank you. We have still time for one or two questions. Dr. Marmor, go ahead.
What about adding psychotherapy, especially CBT type? Does it increase the amount of results?
Oh, I think, and I apologize for not spending more time talking about psychotherapy. I do think that CBT improves results because, and the way that, and I would really recommend the paper that John Rush and I wrote. Unfortunately, the only journal we could get it into was the Australia-New Zealand Journal of Psychiatry. John Rush is the first author, and it's titled Difficult to Treat Depression. The way I look at these folks with difficult to treat depression is I will take from every area of psychiatry anything that I feel will be a help. The same way that I think absolutely psychotherapy helps. I think that exercise helps. I think changing diet helps. I think, and one of the other things that I do with somebody that's coming to me potentially for VNS is the first thing I do is I do a consult on their medications, because it's amazing how many people, nobody stops the medications. When they're not getting better, more and more medications get added. And so one of the first things I do is let's figure out what we can get you off of. And I think all that has to go into treating these folks and giving them some piece of their life back if we can't give them their whole life back. And certainly for a lot of these folks, I have somebody who was sort of a low-level functionary as a dispatcher for a trucking company when we implanted her. She now owns her own trucking company. And it really, and she's pretty clear that, her depression is in better, is in much better shape because of this. But absolutely, I'm a firm believer in psychotherapy. And earlier in my career, half my hours of clinical hours were doing psychotherapy. I just no longer have that kind of time to do it. But I am all for giving folks as much support as we can give them.
Thank you. I think we have the same way of thinking here in Israel, of giving the maximum means we can help the patients. Do you have any other comments or remarks?
I will, the only comment I'll finish with, so I've been somebody who has specialized in treatment-resistant mood disorders for my entire career, and I had my 40th med school reunion this past year, so I've been doing this for a while. I have never had so much stuff to play with. I have never had so many different avenues to go down. And so from the standpoint of being a very curious researcher, this is a wonderful time within difficult to treat mood disorders for our patients and for us.
Okay, so on this optimistic note, I'd like to thank Professor Aehrenson, Dr. Ido Strauss for being the Israeli link here, for going into these new fields and doing it practically, actually introducing these techniques in Israel, to Sigma company that helped us put this evening together, from the Israeli Psychiatric Association, Tel Aviv. And thank you for the audience for being so patient with us in this late hour, and all the best to all of us. Thank you very much.
And I wish you good luck.
Thank you very much.
Thank you.